So we talked about this earlier about, how ALIF and lateral are great operations, but still kind of pale in comparison to TLIF in terms of the, broad adoption around the country. So this slide is specifically for Paul Park. He may have moved to Memphis, but I know his sports heart is still stuck in Ann Arbor. So I actually made this talk before last year, and so this may have been something that put us over the top. But we're definitely the big brother when it comes to the ALIF-TLIF relationship. Okay, so my job is to argue, yes, ALIF is the undisputed best in class. Obviously, from an MIS perspective, we're usually using it to treat degenerative disc disease. We know that ALIF has a huge footprint and excellent fusion rate, and the argument here is that we can get an excellent fusion rate with or without pedicle screws. Foraminal restoration, improvement in segmental lordosis, and affecting regional and global sagittal alignment. So again, this would be some of the common indications, and we'll talk a little bit about some of the papers. I personally haven't used it a lot with lytic spondylolisthesis, but there is some literature, so we'll talk about that. So in terms of foraminal restoration, there's been several studies looking at this. This was a single surgeon retrospective review of 140 patients by Rao. And basically they took different measurements of the foramen, so the foraminal height, foraminal width, and foraminal area. We generally think about the height for the exiting root based on the subluxation of the superior articulating process, but we know that the ALIF procedure can increase all of these dimensions. So you can see 66% increase in area, height, and width. And again, if you kind of looked at the percentage changes, maybe even more dramatic at L5S1 than other levels. ALIF versus TLIF, again, we have to argue that this is the king of the interbody approach for degenerative cases. So this is probably the classic study that most people will bring up. This is an old study done by Steve Andra, 2007, but they did a relatively small number of patients, 32 and 25. And you can see when people come to Seattle Science and they talk about TLIF being a kyphosing operation, this I think was one of the papers that kind of created that narrative. So you could see actually the ALIF, much bigger increase in foraminal height versus an actual decrease or a smaller increase for a TLIF. And then this again, segmental lordosis. So a small increase, 6 degrees. This was in 2007, so I suspect that these were probably 7-degree grafts. And obviously, nowadays we have a bigger, variety of grafts to choose from, and we can match that to the patient's pelvic incidence. Generally, I think I'm in the camp that most people need 35 degrees of lordosis from L4 to S1. So that's basically when I'm doing work at 4, 5, and 5-1 with an ALIF, that's my general target, and the variability is above that. But you can see in this particular study, they actually lost 2 degrees of lordosis with a TLIF. And then again, if you look at level by level, L5S1, this is pretty much where the most dramatic improvement in segmental lordosis, and this is obviously our foundational level. This was another study looking at transforaminal versus ALIF and long deformity constructs. Again, obviously we're talking here about more minimally invasive and standalone options, but certainly I think we would all agree that if you do a bilateral facetectomy and you really do an aggressive intradiscal osteotomy and you're a good TLIF surgeon, you can get some lordosis at 5-1 in these deformity type constructs. But again, when we're looking at degenerative cases, I would say that the vast majority of people, if you're trying to make the surgery minimally invasive, a small outpatient procedure, generally this is a unilateral facetectomy. Most people are putting in an expandable cage. I think that's kind of the rage nowadays. So even when you do an aggressive, more aggressive deformity type TLIF operation, the lordosis for a more minimally invasive approach, you're just not going to match what you can get with an ALIF. And I think this is probably a study that's well known to most surgeons in this room. Kind of the whole argument, like, am I a deformity surgeon or a degenerative surgeon? Do I need to do scoliosis x-rays if I do a 1-level ALIF or I do a 1-level L4-5 fusion? And I think we all have seen, I know for a fact, there's probably 2 patients in my hospital where there's preoperative x-rays of virginal case that was started off by a bad TLIF, and the last operation was a C2 to the pelvis. It can happen. You know, it's crazy how 1-level surgery can go bad. So basically, this was a study just showing that if you don't match and get your PI-LL mismatch, which is, you know, a pretty universally accepted criteria for sagittal alignment, that your risk for adjacent segment disease with a 1-level operation is increased tenfold if you don't restore that distal lordosis. What about the rate of fusion for standalone? So I think, you know, that's, you know, for people that are worried about transitioning from circumferential, approaches where you do an ALIF and then back it up with percutaneous screws. I mean, when I was training, there were no percutaneous screws, so everything was an open L5-S1 posterior lateral fusion, taking iliac crest. But now, obviously, the morbidity of putting in perc screws is pretty small. It's interesting, though. There was a phase where I was doing some spinous process fixation clamps with 1-level laterals. And I have to say that I generally felt that patients actually had less pain with a small midline incision to put a plate on for spinous process fixation to back up a lateral than they did with perc screws. And the whole point of bringing this up is, I mean, while putting in percutaneous screws is a quick thing, and we feel like it's a minimally invasive endeavor, and if you look at MRI scans, you really don't typically, you know, if you go back 2 or 3 years later, 5 years later to do an adjacent segment, I don't think you see a lot of paraspinal muscular atrophy, but I think the immediate pain from the surgery, it changes the postoperative course maybe for the first 3 or 4 weeks if you're able to do a standalone construct versus using even percutaneous screws. But this was, again, just a systematic review, just looking at all the studies out there. And the fusion rate for standalone, very good, 88.6%. And you can see if you plated, looking at the studies with plating, 94 versus 89%. I don't think that was, necessarily statistically significant. And obviously, if you're using BMP, then you're going to get, as close to 100% as possible. I would say that in the past 15 years, I've never used BMP in any of my lateral cages, but I feel like L5-S1, when you go anterior, because the revision for that is, you have to get a good posterior lateral fusion. So I never want my L5-S1 ALIF to fail. So that's the one interbody approach where I'm still putting BMP inside of the cage. Okay, so what about standalone for lysis? Because obviously we all see this pretty frequently in practice. So you have your 40 to 50-year-old patient that's got a lytic spondy. It's only a grade 1. It's not a grade 2 or grade 3 spondy. So again, this was a relatively small retrospective study at a single institution looking at 36 patients. And you can see an 86 or an 84% fusion rate and only 1 reoperation for symptomatic pseudoarthrosis. And you can see most were grade 1 and grade 2. Again, I was actually fairly surprised that there was that many grade 2 slips in this study. Myself personally, I would say grade 2, I'm pretty much always using pedicle screws. But obviously, when you put the patient asleep, sometimes something that looks like a grade 2 on a standing x-ray is already going to be a grade 1. So you're really operating on a grade 1 from a functional perspective in many of these cases. Again, here's another study saying, okay, what are the risk factors for instrumentation failure in pseudoarthrosis after a standalone ALIF? So this instrumentation, obviously there's various ways of doing this. You can use a plate. You can use the screws that are integrated into the cage. Some of the implants now have these self-deploying tabs. So again, this was someone going back looking at a single institution study looking at their patients. So 44 were done for degenerative disc disease, 20 were done for spondylolysis, and you can see there was a slightly higher non-union rate for the patients with spondylolysis, 4.5 versus 10%, and all of those patients that got a lysis with the pseudoarthrosis with the lysis had a breakage of those tabs. There was no plating used in this study. So this was, I think LinkedIn is like the new PubMed, so everyone's been throwing up and talking about this study as kind of a justification for do what you want, like anything works, right? So this was Kaiser Permanente, one of the great medical institutions in the country, looking at all of the surgeons in their registry, so a registry study, like 5,000 patients. So overall, this study was just looking at adjacent segment disease. So I showed you the Rothenfluh study. This one basically said that the incidence of adjacent segment disease was about the same, around 8.4%. The crude incidence, before they did some of the data analysis, statistical analysis, the crudest, lowest adjacent segment rate was with ALIF, but there was really no significant difference once they kind of looked at the multi-variable logistic regression. One criticism of the study is looking at sagittal alignment. So if all of these patients had a pelvic incidence of 40 degrees versus a pelvic incidence of 60 degrees, then I would say that there would be potential that this data would have been a little bit different, but they didn't really look at that sagittal alignment. And you can see, I would say the value of this study is just when you talk to somebody in the office and they say, hey, what are the chances that I'm not going to fuse? I mean, this does give some relatively meaningful data, and you can see over time that the adjacent segment disease is pretty tight, not a big difference between the groups. Interestingly, surprisingly, if you just, again, look at the crude data, it looked like lateral was the highest, and I'm not really sure why that would be. Maybe poor surgical technique and more subsidence, but hard to say. Okay, so technical pearls for the L5S1 ALIF. Obviously, partnering with a great vascular surgeon, Neil talked a lot about the MRI scan review, and when we started doing laterals, we became cross-sectional anatomists. The T2 axial MRI scan for lateral at L4-5 is like the key thing that keeps you out of trouble, and obviously doing the same thing at L5S1, it's critically important. We didn't really talk about this before, but Dr. Santa Rosa is one of the exposure surgeons that does a lot of lecturing. So I like kind of her analysis. So you kind of look at the bifurcation. Obviously, for most people, God kind of moved the vessels out of the way, so there's not a lot of vascular manipulation at 5-1. Just got to take out you just have to section the vessel in between. But if you look at some people, if they have a flat vein, so what you want to see at 5-1 is a round vein with a fat stripe underneath the vein. If you see, even if the vein is, the left common iliac is in the middle of the disc space, if you have a great vascular surgeon, the vein is not flat, it's round, and there's fat underneath the vein, you know that the chances that you're going to get a significant vascular injury is pretty small. If you have someone that's older, you're looking obviously also at the arterial calcification, so that's a significant thing to keep in mind. I think in my 20 years of practice, I've seen one person that had an embolic phenomenon from manipulation of a calcified vessel, but obviously it's the vein that's the critical issue here. Nima talked about the value of intradiscal air, so obviously anytime, even in a patient that maybe has a little bit of osteopenia, osteoporosis, if it's a very chronically degenerated disc and the end plate itself is sclerotic and you have interdiscal air, your chances of not having a successful intersegmental distraction is pretty small. And obviously, we have to pay attention to the facet joints. If you have a degenerated disc and you're like, okay, it's 50% collapse, this is a great candidate for a standalone ALIF, and you don't look at the joints to see maybe they're partially ankylosed, you can definitely blow up the end plate in a case like that. So pay attention to the joints and look for intradiscal air. Preoperative, obviously, DEXA scan. a very interesting case. I think Seattle Science should do a whole course on the metabolic bone health associated with spinal surgery. I think we can listen to lectures all day. Personally, I do pre-treat with these medications. I mean, there's data to show that with about a month's worth of anabolic treatment that there's improvement in pull-out strength of instrumentation, but I guess this is a topic for another day. But I mean, the whole point is that if you're going to do any type of fusion, you really got to pay attention to metabolic bone health. And again, we talked about the imaging. So this is Dr. DeBakey in the middle, and the gentleman to the left is Patrick Reardon. So Dr. DeBakey obviously was the godfather, the inventor of cardiac surgery. So this is Dr. Reardon. So he was one of Dr. DeBakey's last residents. And so, my recommendation is get yourself a Dr. Reardon. And what I mean by that is just, he's, I think, the vascular surgeons that really know how to do this, they understand the spinal anatomy. So spend some time educating them, take them to courses. When I took my first job in Rochester, I had been working with Reardon as a resident for forever. And then the first time I did an ALIF, instead of literally an 8 to 10 minute exposure, it was 2 hours. There were vessel loops everywhere. And I was like, this is not what I'm used to. So obviously, not that what we do as spine surgeons is unimportant, but the vascular surgeon, let's face it, they are the key to the safety and the success of this operation. In terms of positioning, if somebody does have a higher sacral slope, putting a bump underneath, putting them closer to the break in the bed so you can horizontalize the disc space and get more of an inline view of the back of the disc is helpful. I actually, if I have a disc space like this, I have them pull out my XLIF instruments for the angled cob. That is like one of the best instruments to make sure you get the disc space distracted. And I use the interdiscal paddles as well, but for that first instrument, to make sure that we don't violate the end plate and we have the ability to tackle these really steep angles. The angled cops from the XLIF set are really, really helpful. Then we talked about vascular disease. We always mark the pulses, make sure that you can either palpate them or do a duplex or Doppler, and make sure that when you complete the case, if you're going to do a lateral, that you check that in between. One of the things that we kind of do with our positioning, I like to drape in the C-arm. I think I personally learned about how precise interbody surgery is when you do a lateral. So I know a lot of my orthopedic colleagues, the first time they take a shot is when they have a trial in. And for me, especially with very collapsed disc spaces, I use live fluoro and watch the vertebral bodies move, and I just feel like I don't get into trouble violating the end plates, and it's a much more kind of controlled, precise surgery. If we do it for laterals, why should we not do it for ALIFs? And so by wrapping the arms, you can really move the C-arm out of your way, and you're not kind of running into the arm boards. And you can see here, however you prep and drape, Dr. Reardon always tells me, hey, I want to have access above the belly button. If something really bad goes down, you want to be able to make a big cut and not be cutting through something that's unsterile. So we always make sure that we're prepared for the worst. So being as how he was a luminary person for the first 15 years of my practice, basically we exposed with Steinman pins. He said, it'll take me longer to put a frame on than it will to put these pins in, so this is what I'm doing. And as soon as the pins are in, he's going to his room to do his laparoscopic cholecystectomy. But for some reason, he softened in old age, so we finally got him to use the frames. But obviously, any of these things is going to give you the exposure that you want. And personally, I do prefer the frame. In some patients that have osteoporosis, the Steinman pins, as you're trialing and so forth, they tend to loosen. So in terms of the operation, just like with Neil mentioned, the annulotomy, discectomy, sometimes I'll look in and the left-sided retractor is not all the way around the disc space. So one thing, I don't think the vascular surgeons know about the 4 Penfield, so I'll use a peanut to really kind of loosen that areolar tissue, and then slip the XLIF 4 Penfield underneath the iliac vein, and then use that to hold, and then replace the retractor and really get it around the corner. Not so much for degenerative cases, but if you want to put a 30-degree ALIF cage in, you got to do a big lateral annular release. So at 5'1", there's really not a reason why you can't have panoramic exposure of the disc space. If you're kind of waiting for the scrub tech, they're fiddling with the cage, it's never a bad idea to loosen up the retractor and just take a little pressure off the vessels if time is getting a little bit long. If you have a relatively tall disc space, I like to visualize, take the cob and see that plane between the bony and cartilaginous end plate, just separate that, and then use the large Lexel, and you can really almost get 90% of the disc out in one shot if you get into that right plane. And then obviously, I think there's an orthopedic neurosurgical debate about the PLL. I do tend to kind of skeletonize or release that. Again, using the small Kerrison or XLIF curette can be really helpful. And then obviously, if you're doing this for someone that has a recurrent central herniation, you can definitely take the disc out from the front. It's basically like a gigantic ACDF, and I've heard people make that analogy before. But you can definitely take out stuff in the canal from the front. In terms of trialing, I like to use the paddle distractor, so get that wide panoramic dissection of the disc space. And then Dr. Benzel, he has a great picture in his biomechanical textbook. It's the boundary phenomenon, so the finger going on the tin can. So if you get those paddles way out in the ring apophysis, just like we leverage the implants for an XLIF, I'll put in like an 8mm paddle on one side, distract it, take the T-handle off, leave that in, work on the other side, and just go back and forth and segmentally release that disc space before I put in my regular trials. And again, all fluoroscopically controlled. One of the things I always tell the residents is that if you're dealing with someone with osteoporosis, if you're going to use paddle distractors, I always make sure that I'm pushing my hand towards L5, because if you have poor bone quality and you use a paddle distractor and you're aiming more towards L5, it will blow through the bottom of the L5 end plate. So I'm always erring on the side of pushing more towards L5. So you can see this is just kind of that segmental distraction, and then we go through our trialing, and then fluoroscopic control of the depth of the implant. And then again, we're talking about the value of doing standalone. For me, what I have typically done is I'll use at least 3 screws through the cage. I mean, some of the implants only have 3 screws, some have 4. But I feel like, especially if it's a little bit of a taller disc space, again, admittedly, I haven't done it for spondylolysis, but if I did, I would definitely use the screws in the implant and use a plate as well. I think biomechanically, to me, again, I don't think it's been studied, but it makes sense that you can, because the thing that you're really sacrificing with an ALIF is the anterior longitudinal ligament, and it's obviously a very important biomechanical structure. So you can see just putting in the screws and using the angled awl is critical for some of these L5 vertebral bodies. So just to run through a quick case, this is actually my sister's roommate from Michigan. So she and her husband own a pool company, so they moved from Florida to Texas to open up a big franchise, and they're killing it here. No great surprise, but she had a couple microdiscs and then basically had 2-time recurrent disc herniation, and came in with bad intermittent pain and mostly mechanical back pain, a little bit of chronic weakness in the EHL. So you can see there's kind of a recurrent herniation there. The disc is certainly more than about 50 to 75% collapsed in the front. But again, this was clearly someone that had multiple recurrences, kind of the Tiger Woods phenomenon. And you can see on the X-ray in the standing position quite collapsed. Again, I'm going to advocate for looking at all these sacropelvic parameters. I just feel like I learn something every case. So kind of interesting, one of the things that I do in my degenerative cases is kind of look at someone that's lost distal lordosis, how are their other disc spaces compensating? I think I'll show you a couple slides here, but I think it's a pretty interesting thing. So again, L5-S1 ALIF standalone because of the fact that she had significant loss of disc height, no spondylolisthesis, significant shifting, and a very low pelvic incidence. So you can see that's the construct. So in her, I think I put just one screw to L5, and then I used the plate. So this is kind of what I was talking about. If you look at this, so preoperatively, you can see that she had like almost no lordosis in that disc space, and you can kind of see the compensatory kind of hyperlordosis of some of the other discs above L5S1. So you go ahead and kind of restore your distal lordosis, and you can see that the L4-5 disc space go from 11 degrees, so that's a compensatory change. And then after you restore distal lordosis at 5-1, you can see how that uncoils. So it's amazing if you just pay attention to this. This was her 1-year postoperative CT, and obviously I used BMP, a plate, great fusion, no big deal there. This is a different case, but I really like this slide, just looking again at what happens at those levels above the ALIF. So every level had just a little bit of compensatory, either hyperlordosis or retrolithiasis. And again, this goes back to that Rothenfluh study. If you screw this up, those things are not going to get better, and you've probably set your patient up for a early failure. If I have someone that comes back 10 years after surgery, I feel bad about it, but that's the normal process of the spine. You can't stop the degenerative process. If I do an ALIF on someone and they come back in 2 or 3 years and need another operation, I probably didn't do a good job, or I didn't, conceptually didn't really understand that I was dealing with a more significant instability. So again, conclusions. L5S1 ALIF is definitely the big brother to TLIF or interbody. If you've got 50% disc collapse, no significant spondylolisthesis, although we looked at the one study that showed even for some grade 2 lytic cases that a standalone gives you a reasonable fusion rate. You can obviously talk to the patient about the pros and cons of the posterior instrumentation and whether or not you would potentially have to take them back if you think that they're symptomatic or that it's radiographically not fused. Neil showed that you can obviously do this in the lateral position. For a standalone, I would definitely say I prefer to do it supine. We know that compared to a TLIF, that there's going to be decreased blood loss, and depending on your vascular surgeon, probably decreased operative time. And I think all the long-term studies in deformity or in degenerative cases clearly show that, particularly in MIS TLIF, where you're putting in an expandable cage, you're only taking out one facet, that the segmental lordosis restoration for an ALIF is clearly superior. So there you go.
Great, Paul. Very extensive talk on ALIF, obviously. I don't think anyone questions ALIF. It probably gives you the most disc height restoration and lordosis. No one questions it. I think part of the problem is you typically employ an access surgeon, so scheduling can be a challenge. And otherwise, I think you'd use it much more frequently. You made a comment about hyperlordotic cages. At least in my experience, I think like 30-degree cages, you end up just getting subsidence over time. I think, honestly, and then if you're trying to get foraminal compression, even if you don't get subsidence, you're not really getting that much foraminal height restoration. I don't really use hyperlordotic cages hardly at all anymore. I think, something in the 12, 15 degree, to me, just gives you the best option, but I'd like to hear your comments on it.
Yeah, I totally agree. I mean, obviously, you'll see every once in a while someone that has an L2 to L5 fusion that really gets a broken down 5-1 disc, and then it's kyphotic, right? So now you're trying to go from 10 degrees of kyphosis to 15 to 20 degrees of lordosis. So I think people, instead of doing a PSO, that's kind of the one indication where you might do like a 25 or 30 degree, whatever the company has, where you're trying to spare someone an L4 PSO. But I would say, I believe in Frank Schwab's and Virginie Lafage, their concept that most people are going to have the same amount of lordosis from 4 to 1, and the variability for high pelvic incidence is from 1 to 4. So I just literally, as we're trialing, I'm having my reps measure the lordosis, and I would say 90 to 95% of my 5-1 cages are 15 degrees, because a lot of times if you look at the X-rays, they're already 12 12 degrees. Sometimes they get hyperlordosis as a compensatory mechanism. That's one of the things you have to be careful of. If you're trying to restore some lordosis and the cage that comes in, the company that you're using, their standard ALIF cage is a 10 degree, and there is a 13 degree compensatory hyperlordosis, and then you put a 10 degree cage in and you countersink it and don't leave it anterior, you might actually reduce the segmental lordosis. So like I said, I agree that super hyperlordotic cages are really not something that you need to do on most of the cases, degenerative, even in deformity, but I just try to hit the 4-to-1 lordosis at 35 degrees.
Cool. Paul, that was a really comprehensive talk. I really enjoyed that. I have a question for you. You know, it's occasionally, and it's very rare, luckily, but we have those patients that have post-operative neurological deficits after standalone ALIFs. And I always felt that it was related to this marginal osteophyte coming from L5 that sort of, you know, you lift up with the foramen and the nerve root, and the nerve root gets kind of strangulated that. Now, if you have a patient that you feel is at high risk for having that, what is your go-to approach? To do a foraminotomy prior, to do a front back, to do a TLIF instead? I mean, and what's your take on that? How do you identify that? You know, like, can you predict or like, you know, I don't know, just want
Yeah, that's a great question. I mean, I think at the end of the day, it's a little bit hard to predict these things. So the question is, like, I always talk to the residents, okay, there's a spondylolysis and the patient has no back or no leg pain. So we're gonna do an ALIF with perk screws with no decompression. For me, if somebody has a major symptomatic radicular side, Art Steffi used to talk about how in spondylolisthesis, there's always a rotational component, and that I never understood why someone could have terrible bilateral foraminal stenosis and they had zero leg pain on a side that looks more narrow on the MRI scan, but they're only symptomatic on one side, and I think it's because there's rotation. But yeah, I those marginal osteophytes, those, you know, definitely I'm always paying attention to those. But I think the single thing that I've done, and I think Juan talked about this recently in a lateral talk, is someone that's got a collapsed disc space, I'm going with the first height. I mean, you need like a millimeter or two of distraction. You don't need to put a massive cage in because I have one patient that got a bad foot drop from over distraction, just being too aggressive. This is like maybe 12 or 15 years ago. So I'm much more conservative in both lateral and ALIF on how big of a cage I put in.
Paul, great talk. Do you think it makes a difference whether you go transperitoneal or retroperitoneal? And then I guess the second question is, like, how fast do you mobilize people in terms of, you know, their diet and so on? So we're talking about minimally invasive surgery, but if we're keeping them, you know, NPO for a day or two, you know, what do you do for that?
Yeah, I hope to never see a transperitoneal approach, but yeah, we kind of just, you know, put them on liquids and then advance as tolerated. And I think the biggest thing is get them up walking because obviously that helps with ileus and so forth. I haven't really seen a very significant number of patients have, you know, a bad ileus from the retroperitoneal exposure. So it's usually not a big deal. The other thing I didn't mention is in terms of this being a minimally invasive thing, we're doing TAP blocks and ESP blocks on all these, and that's made a huge difference.